mentioned. So now we're ready to begin, and once again, we're pleased to be bringing you this IHSPR policy round focused on Pharmacare in Canada. I just want to review a few of the learning objectives that we have for today's session. You can see them on your screen. We want to spend time to recognize the opportunities and challenges related to reforming Pharmacare policies and systems in Canada. We want to learn about Pharmacare's landscape in other countries and examine research on health spending and health system performance. Third, to learn more about the current Canadian research and understand existing gaps in research in the field. And finally, consider the policy implications of having a Canadian Pharmacare strategy from both a provincial and national perspective. Okay, and just a quick outline of how today's session will unfold. I'll just introduce the speakers quickly, and we'll hear from both our invited experts who will provide us with some food for thought related to research, practice, and policy. And towards the end of the webinar, we'll take questions through the chat mechanism. Once the webinar closes, a survey will pop up on your screen, and we would appreciate it if you could complete the survey just to provide us feedback on how the session has been. This helps us form future sessions. So thank you in advance for doing that. So without further ado, our first presenter that I'll introduce is Dr. Steve Morgan. He is a professor in the School of Population and Public Health and director of the Centre for Health Services and Policy Research at the University of British Columbia. He's also the leader of Canada's Pharmaceutical Policy Research Collaboration and a member of the Evidence Network of Canadian Health Policy. He's received numerous career awards, including one from CIHR, and he's been commissioned to provide policy advice to governments in Canada and abroad, the World Health Organization, and the Organization for Economic Cooperation and Development. So Stephen will start, and our second presenter that I'll introduce is Matthew Broham. Matthew joined the Canadian Agency for Drugs and Technologies in Health in 2011 as the Vice President of Products and Services. He is responsible for overseeing the research, development, and delivery of the agency's products and services that contribute to the optimal use of drugs and health technologies in Canada. As the former Chief Executive of Pharmac in New Zealand, Matthew has significant expertise in maximizing the health benefits of pharmaceuticals through the use of objective economic assessment and prioritization processes to support evidence-based decision-making. So with that, I'm going to turn things over to Dr. Stephen Morgan from the University of British Columbia to start us off with his presentation. And you can, again, feel free to type comments in the chat box, and we will address your questions and answers towards the end. Thank you, and go ahead, Stephen.
Thank you very much. I hope everyone can hear me. And I just wanted to say thank you for joining us today on the call. I've just had a quick scan of the participant list, and it's an impressive group, and I'm happy that I've met many of you, and so I hope you'll enjoy this, for many of you, lunchtime conversation, and for those in Western time zones, maybe it's an early morning seminar for you. I want to just extend my thanks to CIHR for the invitation to speak, and also for financial support of the Pharmaceutical Policy Research Collaboration, which is one of the CIHR-funded emerging teams that was funded a few years ago, and in our case has supported a network of approximately 21 university-based academics who study pharmaceutical policy issues in the Canadian health system context. So I'm going to jump right in and remind us a little bit about the Canadian healthcare system. We all have a fairly intimate understanding, I think, of what Canadian Medicare is, a universal public health insurance system that provides access to healthcare for all people, regardless of their ability to pay and based on their healthcare needs. Canadian Medicare, I think, is a source of national pride for many people, and is something that every year when we hear polling about top priority issues in the Canadian political landscape, maintaining and enhancing the public health insurance system and Canada's universal healthcare system is a top priority. If Canadian Medicare is a source of national pride, I would argue that Canadian Pharmacare actually ought to be a source of national embarrassment. And the reason is that every developed country with a universal healthcare system provides universal coverage for prescription drugs, except Canada. But we are conspicuous in the international landscape insofar as that we have left prescription drugs outside of the system of universal coverage for healthcare. And in essence, over the last roughly 50 years now, have left prescription drug coverage to a mix of private and public insurance, a system that leaves many Canadians without coverage whatsoever. This was not meant to be the case. In fact, one could argue that Canadian Pharmacare is a work in progress. The original fathers, as it were, of the Canadian Medicare system had envisioned that we would extend universal public health insurance to include not just hospitals and physician services, but also eventually in stages to expand that coverage to include coverage for prescription drugs, home care, and other essential healthcare services. We haven't got there, and as a function, what has happened over the last, again, roughly 40 or 50 years is that provinces have, on their own, developed a number of different pharmacare programs to address the needs of the populations that they had, and they did so, to be clear, without financial assistance from the federal government, which is in stark contrast to the systems of coverage for hospital and medical services, which are partly cost-shared by contributions from the federal government. I want to review three of the provincial models of pharmacare in this country that actually stand as, I guess, archetypical models of the options that we see within Canada for structuring pharmaceutical benefits, and then contrast that with systems that you'll find abroad. The first of the models that I will look at is that for Ontario, which is, in essence, perhaps could be seen as the quintessential model for publicly run pharmacare programs at the provincial levels, as it was approximately a decade ago, when most provinces in the country provided provided comprehensive benefits for senior citizens and for social assistance recipients. Ontario also provides a universal safety net of a high deductible catastrophic drug coverage for people who are not on social assistance and not senior citizens. And that system of a safety net for the majority of the population, comprehensive public for the elderly and the poor, was in essence deemed to be the minimum national standard by the Romano Commission in 2002. And I'll contrast that system with two other options we see in Canada. One is the British Columbia model, and it's not unique to British Columbia. In fact, as of next year, all Western provinces will have a model of this kind. This is a model of insurance that involves high deductible coverage from the public system for drug costs that exceed certain percentages of household income. For most households in British Columbia, that percentage is 3%. And this unique feature of these systems is that they, in essence, have eliminated the comprehensive coverage for senior citizens and replaced them with the universal safety net for all people, regardless of age. And then thirdly, the system that I think is interesting to look at in the Canadian context is that of Quebec. Quebec's system is unique, or was unique up until this year when New Brunswick adopted a similar policy tool. As of 1997, residents of Quebec were required to purchase insurance of one form or another to cover prescription drugs. In essence, all employers that offered any kind of insurance for health or disability benefits in Quebec were also obligated to provide their employees or retirees coverage for prescription drugs that met minimum provincial standards, and they were to provide that through private markets. All people who didn't qualify for such coverage through their employment or occupation were required to purchase a premium-based drug insurance plan through the public system. And this is a form, if you will, of social insurance that looks a little bit like Obamacare in the United States, only it's unique insofar as it isolates prescription drugs and the insurance for that from the management of the rest of the healthcare system. I want to compare those three provincial models to a few of the international comparators that we might look at. For simplicity and just given the time constraints on the phone call, I will only look at two models. That is one of the Netherlands, which is a universal social insurance model that covers prescription drugs along with all other forms of formal health care through a compulsory social insurance scheme. And the other I will look at is the United Kingdom, which is a classic comparator for Canadian health policy insofar as it is a universal public system for covering a broad range of health care, including prescription drugs. I want to first highlight probably the most important goal with respect to prescription drug coverage and prescription drug policy, and that is ensuring that patients have access to medically necessary drugs without financial barriers or otherwise. And this slide here reports the percentage of the population in different provinces, the 3 provinces of interest, and in the different countries, Canada, the Netherlands, and the United Kingdom, the percentage of the populations in those jurisdictions that report that they have either skipped doses or failed to fill prescriptions altogether owing to the out-of-pocket costs that they face when purchasing a prescription drug. It's very easy to see here, for instance, that British Columbia in the Canadian context has a very high rate of cost-related non-adherence, financial barriers to medicines. Ontario and Quebec fare better, in part because of the compulsory insurance in Quebec and in part because of the seniors drug program in Ontario with relatively low co-payments for seniors to fill prescriptions. But it's nevertheless the case that both Ontario, Quebec, and certainly the Canadian average have rates of financial barrier that are between 2 and 3 times that found in the Netherlands and approximately 5 times that found in the United Kingdom. Simply said, these systems with universal coverage of prescription drugs, notably at little or no cost to patients that fill prescriptions, provide better access to the medicines that are prescribed by doctors. I want to speak briefly about financial equity. As an economist, this is something of interest to me because, as many people in the world of health economics know, one of the things to consider in designing health systems more generally and Pharmacare systems in particular is that the financing of medically necessary care should not exacerbate prevailing income and inequality in a nation, and that individuals should be protected from undue financial burden as a function of their health care needs. Again, similar chart showing the percentage of patients, in fact this is percentage of households facing over $1,000 in out-of-pocket costs owing to prescriptions filled by their household members in the 3 provinces, the Canadian average, and then again the Netherlands and the United Kingdom for comparison. British Columbia is approximately comparable to the national average, of course, because there is a system in place to protect people from high costs in terms of public coverage beyond catastrophic deductibles. Ontario, of the 3 comparable provinces, does the best because it has comprehensive coverage for seniors plus that safety net for all other people. And Quebec actually, despite the fact it has a system of universal coverage by way of compulsory insurance, it has very high out-of-pocket costs because that market is structured very much like an insurance model. There's co-insurance deductibles and charges that patients will face on a regular basis, and the family household maximums are defined basically on a per adult basis, which can result in significant financial burden in terms of out-of-pocket costs over and above the premiums that people in Quebec pay for the insurance that they get. Lastly, the important comparison here, of course, is to the Netherlands and the United Kingdom, systems with universal coverage of prescription drugs with little or no cost to patients. It's therefore no surprise that they have very few patients reporting significant financial burden as a function of the prescriptions that they fill. And I should point out that the rate of prescription drug use in these countries is not dramatically different than that in Canada. In fact, the share of the population that fills at least one prescription for their needs, no matter how you stratify it by age or health status or income, is approximately equal in the Netherlands and the UK to Canada as a whole. And lastly, I want to talk a little bit about efficiency, the degree to which the system is able to manage the expenditures on prescription drugs and see how Canada fares relative to our international comparisons. This figure here is prescription drug spending per capita adjusted for inflation over the period of 1985 to 2010. And this is Canadian profile of drug spending. You can see it's been relatively stable growth for many, many years in Canada, flattening out just slightly. And if you extended this further to 2014, you'd see a little bit more flattening out as the provinces have managed to secure more savings from generic drugs, the increasing availability of them, and lower generic prices over the past roughly 6 to 8 years. But if we compare that to the Netherlands, a country that started at a lower rate and stayed at a lower level throughout the period, you'll notice that Canada may not be doing as well as a comparable country with universal coverage of prescription drugs. If you looked at that per capita difference at the end of the series here and projected that to the entire population of Canada, that is tantamount to a difference of $11 billion of spending or $11 billion of potential savings that would accrue every year, year after year after year. And similarly, if you compared us to the United Kingdom, the difference between us now and the United Kingdom now on a per capita basis projected to the entire Canadian population would equate to approximately $14 billion of savings year after year. To put that in context, that would be enough money to increase the nursing workforce in Canada by 50% or to double the number of family practitioners in the Canadian physician workforce. So $14 billion, I don't think anyone would argue is non-trivial. It's real money even in the context of healthcare budgets. And in case you thought I was cherry picking, this is the rest of the OECD sample, all comparable, reasonably developed countries in the world. I've left the United States off this graph because it's actually higher than us, but they're hardly a relevant comparison given that they don't have universal coverage yet, and they're known to have the highest prices of medicines in the world. So that's not necessarily the benchmark that we would strive for. And lastly, also, in case you thought, well, these other countries that manage their drug costs may actually be sacrificing research and development investments in their country, I would just compare us, Canada, against the Netherlands or the United Kingdom and note that Canada has approximately half the degree of pharmaceutical research and development on a per capita basis that the Netherlands achieves, and the United Kingdom actually achieves roughly 5 times as much R&D investment in their country, despite the fact that they actually have far lower spending on medicines through their universal system of public coverage. So just to be clear, I want to go to a couple of take-home messages in terms of provincial models. Is British Columbia the answer for Canada? Is this the model that we should be embracing on a go-forward basis? There are a few problems with the BC model. One is that the house burns down every year, so to speak. High deductible insurance coverage is more or less meant to be a motivation for things that might happen once in terms of a disaster to a household or family. But in the healthcare context, as I'm sure all of you on this phone call know, if you have chronic disease requiring high-cost medicines, the proverbial house burns down year after year insofar as you will have those high needs for medicines year after year, likely until death. A second concern with the British Columbia model is that it leaves a lot to the private insurance sector, which by its own admission now actually has fairly significant medical losses in terms of high administration costs and profits paid to the firms running the systems. Particularly in the insured markets for prescription drug coverage, the industry estimates that their medical loss ratio is 18%. That would be the equivalent of the provincial drug plans having an 18% administration cost, when in fact their percentage of administration costs are probably closer to 5 or 3%, depending on the numbers you look at. Lastly, there is a bit of a fallacy in terms of the retirement benefits for people who have enjoyed work-related prescription drug coverage in a system like British Columbia's, where I think the government and others might have hoped that retirees would be covered by their workforce or their workplaces. And increasingly, unions and employers are sitting down and realizing that they can no longer bear the cost. And it's no surprise if government thought it couldn't afford the cost of drugs for the baby boomers. It's probably fair to say that it was a false assumption to think that the private sector could have borne those costs in a better way. And lastly, there's a fragmented buying power that occurs in any system involving multiple payers. And in essence, a multiple payer system favors the seller, not the purchasers. And in pharmaceutical policy, that's probably not the best thing for a nation like Canada. And sorry, this is the final note on BC's. We talk often about systems with multiple payers as being systems that may unleash the forces of competition and innovation. And in fact, it's probably more like the case that they've let go of the reins on drug spending in a province. And just to give you some data on that, this is British Columbia private and public spending from 1985 to 2010. And in the context here, the government spending was well maintained after the implementation of its income-based drug benefit program, which was phased in 2003. The problem with the system has been that the private expenditure on medicines in British Columbia made up the difference. And in essence, the pressures on unions, employers, and uninsured British Columbians has been very significant in the decades since that policy change. Is Quebec the answer? Very similar system, a set of concerns. I'll go through them quickly. Quebec also suffers from using private insurers that are not particularly administratively efficient. We, in Quebec, now see an increasing strain on unions, employers, and retirees because of the assumption that workplaces would pick up the benefits for their retirees. The system certainly fragments purchasing power in Quebec. And again, is it unleashing the innovation that could come from multiple payers? Well, not necessarily. In fact, not specifically in a context where the payers are not responsible for managing the total healthcare system. Quebec drug spending increased dramatically following the 1997 implementation of their universal insurance system. Some people would argue that that's the cost of getting better access, but I would remind you that in the international context, all countries that provide universal coverage in a way that's integrated with the rest of the healthcare system do so at lower cost. And again, look at the data from the Netherlands and the United Kingdom, and you'd see that Quebec is an outlier insofar as it has achieved universal coverage, but at an extraordinarily high cost to the individuals in that province. Just to put it in context, the difference between the rest of Canada and Quebec today is approximately valued at about $1.3 billion in the province of Quebec, or an additional spending on medicines of about $1.3 billion relative to the average in the rest of Canada. So where do we go? What are the policy recommendations that can be extracted from this? Well, in some sense, we ultimately are going back in time, because we know that we've been talking about Pharmacare in Canada, universal public single-payer Pharmacare system since the 1960s. The question is, how do we, in essence, develop the political will to make it happen when, if there are billions of dollars to be saved, it also means that for some stakeholders there are billions of dollars to be lost. I would remind us that every developed country with a universal healthcare system provides universal coverage for prescription drugs, so we know it's possible. In fact, I've often been asked, can you point to an example of a country that's done this? And I would say, well, I could point to virtually every other country in the OECD. The question is, do we have the political will to get there, and what would it look like? One of the things I think we need to remember is that as a country and as in the individual province, we need to be using collective purchasing power and better integration of the system so that we can get better value for money. That will mean increased access. So for some patients, it will mean increased use of medicines. For other patients, it might mean increased use of generic medicines. But I think in essence, if I can use the line, we need an LCBO for Ontario. As many of you may know, the LCBO is the world's largest purchaser of wine, spirits, and beer, and it obtains among the world's best prices for the alcohol that it purchases on behalf of the distribution channels for Ontario. In essence, we need an LCBO for prescription drugs. And there's one example, and this is, I guess, a good segue to Matthew's presentation, that I would look to internationally as an example of what that purchasing power can do. New Zealand, in essence, has a single purchaser for its country. And if we compared the same drug in terms of 30 of the top-selling pharmaceutical products from 11 of the most commonly prescribed drug classes in Canada, we actually did some comparisons. A brand prescription for approximately 1 week's supply would be approximately $13.60 for the brands of these drugs in Canada, on average, that is. On average, the generics would be about $3.40, so it makes very good sense that for the vast majority of patients that they would receive the generics. But note that the generics in New Zealand, which are purchased through a single payer, would cost only $1. The difference is quite significant. These drugs have approximately $5 billion worth of sales in Canada of brand and generic form, and there's about $1.5 billion of that goes to dispensing fees for pharmacists. Even if dispensing fees were unchanged and we adopted a system that priced drugs roughly comparably to those in New Zealand, Canada could save between $1.5 and $2.5 billion on these 30 drugs alone, depending on how often we use generic substitution when appropriate. So with that, I'll say thank you very much and pass the green ball from this slide deck
back to Matthew and to the hosts for the second part of the presentation.
Thank you, Dr. Morgan. That was a standing overview of the situation in Canada and also with a view to some of the comparisons to other countries. So I think that raises lots of important questions and things for us to consider that we can take up in the chat portion of this webinar. And while you're thinking of your questions, and I'm going to ask Matthew Brome now to present his slide presentations for this webinar. So Matthew, you'll have the ball here in a second. How if you just want to pass that over to Matthew, and then we'll get started with the second slide presentation.
Absolutely. So Matthew, you have the ball now.
Okay, thank you. I was just, I saw the ball, but the slides weren't coming up. So anyway, here we go. So just to put things in context, Canada has 13 provincial, territory and drug plans, around 5 federal plans, and somewhat astonishingly to me, somewhere in the order of 250 or more private plans. As a result, it basically has pretty broad coverage for most drugs, for most people. So to use a lovely Canadian expression, could always be better, but it's not too bad, eh? Well, why should we change? I think one of the key drivers of change towards, in terms of some policy, whether it be national Pharmacare or something else, I think the most important pressure, or the pressure that will bring the most to bear, is actually geographical inequity. I think of this as horizontal inequity, but it's not linked to any sort of income. This is just treating the same people differently on the basis of where they live. And back in the day when I first started in public policy, I was a tax analyst. It dawned on me as a tax analyst that as a consequence of the letters that my minister received, that horizontal inequity was reserved for the most vitriolic of exchanges. When people saw their neighbours roughly in the same situation as themselves get treated completely differently, they were incensed. And I think, so for this reason, I pretty much think that one needs some form of consistency across the country. And when I talk to Canadians, this is one of the things that irritates them the most. I wasn't here, example, for the listing of Lucentis, or to put it another way, the lack of listing of Lucentis in various provinces around Canada, but I was in New Zealand at the time, and I did hear the anguish that this was causing, and not surprising. Despite how justifiable these sorts of differences are in the Canadian context, I really do think that these strike at the heart of what it means for nationhood. So variously, we have geographical inequity in Canada described from somewhere in the order of 50%, not much better than a coin toss, to 80 or 90%. And indeed, I understand Steve's done some work in this area as well, and if one tries to control for, say, the importance of some of these differences in the decisions, then some of that difference disappears. But nevertheless, differences remain across the country, and these are quite destabilizing. The second pressure, I think, that really forces us to think about change is the vertical inequity that you see in a system. And there does seem to be some evidence out there, as one would anticipate, but clearly quite difficult to elucidate, is that vertical equity does harm health. Vertical inequity, I should say, does harm health. I'd like to highlight some work done by Booth and her colleagues. She looked at well, I should say they looked at the effect of household income on the outcomes amongst diabetic patients. They looked at 600,000 patients off the Ontario Diabetes database. They followed them for 6 years. They controlled for things like age, gender, previous cardiovascular disease, and primary care physician visits and comorbidity. There are obviously in a study like this lots of things that they were unable to control for. They looked at household income, not individual income. They were unable to look at ethnicity differences, lack of insurance coverage in the younger age groups, exercise and diet and things like this. However, we look at this slide, what we see, just glossing over it in a very broad terms, is that there's a considerable worsening in outcomes as household income decreases. We see this as much greater for the age group in this graph that are under 65 years, and the variation dramatically declines with access essentially to the public drug plan, which is represented by the group age 65 plus. The authors calculated that as many as 5,000 deaths and 2,700 events would have been avoided in the under 65 age group if the difference between quintile 5 and quintile 1 was the same in the over 65s group. If the difference for the under 65s between those two quintiles was the same for the over 65s. Now, this is a signal. It's not definitive evidence. The authors went on to try and examine exactly what was causing these effects. They did look extensively at data, some survey data around people filling their prescriptions and how that was related to their income, and found similar sorts of relationships. So if you're a betting person, you would feel a need to actually conclude that this is a fairly important signal. This is indicating that vertical inequity does have quite significant health impacts, and in fact diminishes them quite substantially. So what else? Oops, I'm going backwards, sorry. So I think another reason you might want to think about changing the system is that governments are in debt and their health budgets are approaching 50% of government expenditure. So when governments are in debt and health budgets are threatening to crowd out all other services, any budget line that is growing tends to be a bit of a problem. Now, I was recently exposed to IMS Brogan, who's done their latest 5-year forecasting. I have to make mention that this work was sponsored by Merck. I think it's a very good piece of work, but the long and the short of the information is that we're looking at, over the next 5 years, somewhere between 3.5% and 4.5% compounding annual growth. That's, not, you know, by historical standards, not enormous, but as I said, in a context where governments are in debt and a budget line is growing at that rate, that's a problem. And it's particularly a problem if one believes that this growth rate could be significantly lower. Now, why would I say that? Well, I think the signs of inefficiency in the system are actually very obvious, and I'm going to list a few here. Now, I have done the calculations on the back of an envelope, and the reason I've done that is just to show that the signs are pretty obvious. In New Zealand, I'm not going to get the same figures as Steve just presented, but I'm trying to compare like with like here, and I've bundled in the dispensing fees to be able to compare with some figures I heard from IMS Brogan for Canada just recently. So in talking in US dollar terms, New Zealand spends in the order of about $1.6 billion, covering 4.5 million people. Population in Canada is about 35 million, so proportionally their spending in Canada should be around US $12.4 billion. Currently, the spending in US dollars in Canada is around $21.5 billion. So just on that basis alone, it's looking like there's, you know, somewhere in the order of 40-odd%, 9 billion in terms of savings. If the public plans are about half the expenditure in Canada, then roughly speaking, there should be around $4.5 billion US, which is about 4.7 in Canadian dollars. So that's the first sign, right? We've seen price comparisons, and Stephen has pointed those out pretty extensively, but there's also work from people within his team. Michael Law back in 2012 looked at price comparisons across some key drugs that were off of patent, and I'm not going to read them out to you. You probably all know the signs there. Substantial differences in price compared with other countries, and in particular in those cases, comparisons with New Zealand. Other signs of inefficiency, when you start to think about it in broader terms like allocative inefficiency, you know, I'm always been astounded by the number of pharmacies, not only in Canada but in New Zealand as well. But in 2009, it was estimated there was something like 8,000 odd pharmacies in Canada, and that at the same time is roughly 40% more than in the US. Other research from Michael Law back in 2011 suggested that there were somewhere around 3,300 pharmacies in Ontario alone. And I always love the comparison with the number of Tim Hortons that there might be in Ontario, that number being about 1,000. Again, to me, that's a signal that there's something odd about this setup, that there's some considerable inefficiencies in the system. More recently, I read some interesting headlines about Valiant, for example. I'm quoting here from the Globe and Mail. A valiant effort, growing drug maker can't stop buying. And so this article indicated that over the last 3 years, Valiant had inked something like 14 billion in deals. And in fact, one of the key investors behind Valiant, another headline, hedge fund manager Bill Ackman, Valiant Ackman launched 50 billion hostile bid for Botox maker Allergan. And what really took me by in the article was a statement along the following lines. Mr. Ackman said he's now a convert to the pharma business, at least the way Valiant runs it, and he plans to do more deals with the Montreal-based company if this takeover comes to fruition. These sorts of statements from investors who will basically invest where their dollar is likely to give the greatest return seem to me to be, again, a very strong indicator that we are talking about a market that has some excess profit in it. Now, all of that would be fine if that excess profit was producing large amounts of social welfare for Canada. And I'm just going to end with one comment here. It's not particularly clear that it is producing a great deal of additional productivity for Canada. And again, you know, being a betting person, I'd suggest the evidence is on the side of it's not. So I'm quoting here, or not quoting actually, I'm trying to paraphrase some of the work from Marc-Andre Gagnon, looking at the on-patent market in Canada. In his statement, work done in 2010 rather. So in 2010, potential savings from encouraging New Zealand-style price competition in Canada exceed by more than 5 times the spending on pharmaceuticals research in Canada that year. So one of the areas we'd expect to find some profit being used is in the R&D game, and we would anticipate that being one area that would drive productivity in Canada. But as Steve has pointed out in some of his slides, and as that statement from Marc-Andre tends to suggest, is that the overspending on pharmaceuticals, if I can call it that, is not necessarily generating much in the way of additional social welfare for Canada. So the way I've set this up is if you've got all of it, got all of these problems, and National Pharmacare is, as given the topic, is clearly going to be the solution. If we just had National Pharmacare, then it would all be rainbows and ponies. So the next part of my presentation, I'm just going to think about, well, what would really National Pharmacare look like? And I want to talk about that in terms of outcomes. And just to cut to the chase, really my point is that National Pharmacare, in my view, is a vital ingredient, but it's not sufficient by itself to produce the sort of benefits that we'd really like to see. And I just want to, as a consequence really of my experience back in New Zealand running a National Pharmacare program, what those other factors need to be in order to really get at and improve on some of these problems that we've been looking at here. So you'd have a single formulary across the country, so presumably we would no longer have any geographical inequity. Well, it's not quite true. We'd still have hospital formularies, and we'd still see a number of disparities or differences across the hospital formularies across Canada. We'd also continue to see cancer care schemes in place that are likely to be separate from any form of community-based pharmacare program. And to continue with the theme right from the beginning, we cannot in Canada forget about the private insurance sector. So there would still be, to some extent, a private insurance market there. And I suspect that might diminish over time if you had National Pharmacare, but nevertheless you would still have some of that insurance there. I wanted to make the point also that even when you go down policies like this and you reduce this sort of geographical inequity, for example, in New Zealand, that was not a problem, that geographical inequity was not a problem from the bottom of the country to the top of the country, but it did have hospital formularies that were different, and this still led to much gnashing and wailing of teeth. What did New Zealand do about that? Well, ultimately it put the hospital formulary into the management of a hospital formulary into a single purchaser as well. And then once you've worked with that sort of disparity and tried to eliminate that, you then get the next comparison, which is a comparison across the border. And so New Zealand would frequently be compared with Australia, and I've got no doubt that in Canada people would very quickly, once the geographical inequity in Canada was remedied as much as it could be, there'd be comparisons with the US. So the other area that one would anticipate there being some benefits from a National Pharmacare program would be in the area of vertical inequity. So this is the disparity comes from people who have different levels of income. One of the issues here is that I don't think National Pharmacare really is absolutely a necessary condition in order to have an improvement here. But it certainly would make it easier. It's much harder to coordinate policies across multiple plans in order to deal with this sort of issue. So I just put that out there. It's quite clear from this side that I think the main issue here are co-payments and the differences that would come as a consequence of different policies in terms of co-payments. If you look at the booth work, again, my guess is that it's the co-payments largely that is driving that effect. That is that as you move down in your income level, the co-payments become more and more of a barrier to access. It's interesting, again, in New Zealand, the policies that were followed in New Zealand with respect to pharmacare management led to quite a reduction in expenditure on pharmaceuticals. And the government of the day found that quite a satisfying opportunity, because when every other country in the world was increasing its co-payments, it reduced its co-payments. Now, we compared New Zealand with Australia, and at the time, New Zealand reduced its co-payments from $5 to $3, zero for a number of people meeting certain characteristics in the population. Australia was following policies to try and reduce expenditure by increasing its co-payments. I would suggest to you that those policies are not great for health outcomes, as you would suspect given that information from the booth work. Now, having a single purchaser, a national Pharmacare plan, would suggest the ability to reduce expenditure. But again, I'm going to add a cautionary note here. I think it really depends on the drug plan manager's objectives that are set for them. And I'd also add that it depends on a number of structural elements in the way that these organizations are formed. So the questions I would have around various complementary policies that you would have to have in here is, would raising price competition be one of the incentives, if you like, that were given to the drug plan managers in this situation? The alternative is that there is some sort of policy within the drug plan to not only try and gain some improvements in price competition, but to at the same time try and support the producers in some way, shape or form. Now, this is something that was never an issue in New Zealand because there are very, very few, if only a couple, of producers, and they were both in the generics market. So it was very easy for Pharmac, when it was set up, to have a relatively simple single objective to follow. And this made its ability to actually achieve price competition a whole lot easier, as you can imagine. Another question that would need to be resolved is, are you trying to manage access to pharmaceuticals and actually let expenditure fall where it might, given policies around trying to increase price competition, or would you enforce some sort of objective on the drug plan managers to actually manage within some sort of capped expenditure level? And I think it's pretty clear from discussions around the world that the latter tends to create stronger incentives for the managers to look for price competition effects. In short, really what the policies and the structure that you put in place has to really be able to contend with is, can the manager say no to some proposal that's in front of them? If the political ability to influence that is high and the ability to say no is low, and as a consequence your ability to negotiate price reductions is diminished quite substantially. So when one thinks about having national Pharmacare, one needs to also think about all of these structural elements, and I've mentioned but a few, at the same time, in order to think about whether or not you will achieve the objectives of reduced costs as well as improved health and improved effects on equity. So lastly, I'm just going to look at one of the criticisms that you might expect to see when one talks about national Pharmacare and some of the other incentives that I've talked about, i.e. trying to reduce expenditure, i.e. the ability to say no, and as a consequence the impact on what is and is not made available on the formulary. The criticism is simply one of the formulary ends up having fewer drugs on it, and therefore to some extent reduces patient choice. Now, there's absolutely no doubt that when Pharmac was started in New Zealand, when the National Drug Plan was put into place, that the key objectives at the time were to get some control over the growth in expenditure rates. And to do that, there was some fairly difficult decisions that had to be made that did ultimately result in some reduction in patient choice. But I'll put here under this point that it really depends on the implementation approach. I would say now that the way that that a national Pharmacare program can, in fact, deliver on these objectives of reduced costs, of fixing the inequity problems in the system, and at the same time not severely impact on patient choice. And the reason for that is because I think there are many mechanisms in place where you can actually have stepped approaches to therapy to give patients options after they've tried the lower priced products, etc. And particularly when you are applying these approaches to countries of greater scale, for example, like Canada, you do have the ability to have greater flexibility. By that I mean you've got enormous capability here to have regional differences in say, for example, tender programs that would allow you to manage not only this effect but other effects that might occur, say, from sole supply tendering approaches, etc. One of the mechanisms that's been extensively used in New Zealand. So I'm going to stop there. Here's my summary of all of that. National Pharmacare in some form, in my view, is a vital structural ingredient to improving the welfare of Canadians. But it's not sufficient by itself. With complementary policies, however, it could reduce inequity, increase health outcomes, and improve national productivity, perhaps even with some change to spare. Now, I am somewhat surprised that there could be a policy option sitting out there on the landscape that can offer all of these things and would not actually be taken up. It's rare, in my view, that you come across public policy options that offer you all of these benefits.
Thank you, Matthew. That was an outstanding presentation. And we're drawing to the question and answer portion of the webinar at this point. And while we're waiting for some of the participants to type in their questions and comments, Stephen, perhaps I could ask you to just provide some reflections on Matthew's talk and any comments you'd like to add. And then I will start to read out some of the questions that we're getting in now from the participants.
Yeah, thank you. I'll make my comments or reflections brief. I've known Matthew for a long time, both when he was in New Zealand and since he's arrived in Canada. I think we were lucky to have him come here and share his insights today, but also move to Canada and work with CADIS and bring his insights to the country. I think on the whole, I agree. Pharmacare is national, public, single-payer. Pharmacare system is in the interest of this country. You know, we've known this for a long time, and that's the big shame. And I think that Matthew pointed this out. I've been studying Pharmacare for 20 years, but you know, my mentor, Bob Evans, who I studied with as a graduate student in the 1990s. He had looked at this very same question following the Royal Commission on Health Services in 1971, I believe. He published a book on options for Pharmacare and Dentacare in Canada. And you know what, that book, similar to the Hall Commission, was more or less the same roadmap that we would be recommending today. Exactly what Matthew outlined. You need to have controls in place to make sure that Canadians get access to the drugs that they need when they need them, and that those drugs are competitively priced. And the only system proven the world over to do that in an equitable and efficient manner is to integrate the funding of medicines with the rest of the healthcare system. And so the challenge, of course, is politics and political will. I don't want to blame government on this, but the reality is that we as a public, we as Canadians, need to encourage our government that they could win an election, they could, you know, form government or at least stay as government if they put the interests of the average Canadian above the fairly concentrated interests that stand to lose if we were to reform the system. Because as my mentor Bob Evans was frequently said when talking about health policy reforms in Canada or abroad, every dollar of healthcare expenditure is a dollar of somebody's income. If we're saying that we can reduce expenditures while improving outcomes, it still means that we're reducing expenditures while also reducing incomes. And it's those incomes, the actors that would find themselves with less profit or less revenue, that we need to be able to confront and to be able to have a meaningful answer to all of the potential rhetoric that has surfaced over the years around why Canada cannot afford Pharmacare or why Canada needs to use the forces of competition in its prescription drug sector. So I think that's the next step for Canada, is to mobilize Canadians in a meaningful dialogue that puts evidence first and and make sure that we give our governments the political support that they would need to take on those strong interests.
Any final remarks, Matthew?
No, I think it'll be great to hear the questions. Yeah.
Okay. So we've got a couple of questions here, and I'll just remind everyone on the line that to type in your questions, please use the chat box in the bottom right corner. And if you can direct your questions to all participants, then everyone will be able to see them. So I'll start with these first ones. First question is, why are Canadians paying more for the same medicines than other countries? Stephen, did you want to tackle that one, or Matthew?
So my answer to this is that we have structural inefficiency in our system because we involve multiple payers, and in a system, in any system where you have market power on the selling side and multiple payers on the buying side, you favored the payers. And there are few systems around the world where they're organized as we are, and that's one of the primary reasons, is that we just haven't consolidated our purchasing power. And to Matthew's point as well, we also haven't actually held anybody's feet to the coal in terms of making sure that someone's responsible for not passing the buck in terms of shifting co-payments or deductibles, but actually managing the spending. And so I think the combination of those two things has resulted in a system which is a bit of a laissez-faire market, and that laissez-faire market results in high prices.
Yep, sorry, Matthew.
Yeah, sorry. I'd just add a comment to that, and that is the drug plans within Canada are attempting to do something about this, and to the extent that they're capable of collectively working together, they are beginning to have a bit of an effect on this. So I think it's been well recognized that you need to concentrate buying power, as Steve said. You need to prevent the ability for whipsawing. It's a term that basically means because one party falls, all the others have to fall into line. So it prevents a strong negotiating position on the part of the buyers from coming into play. And as a consequence of knowledge of these issues, there are within the Canadian context, there is some effort being made now to try and put instruments together that do deal with these kind of effects. They're fledgling, and they're beginning to have a bit of an impact in the patent area, but it would be great, I think, to see these solidified and given some greater formality going forward. So what I'm referring to here is the Pan-Canadian Pricing Alliance that has done about 20 to 30, I think, deals, if you like, proposals, agreements, and it is a good attempt to try and begin to deal with some of these issues around not having collective voice, essentially.
Okay, thank you. The next question, if National Pharmacare program were to be made available to all Canadian residents, subsequently causing a reduction in private payer market, could the savings resulted from single payer buying power, et cetera, be eroded by the increased utilization and shift from employers paying for these benefits to the public system?
I'll take that one on very briefly. The reality is that you will see a shift from from private to public if you're going to go towards a universal system for covering even if it's selected medicines for all Canadians, the coverage means that the financing will move not through the private system but through the public system. This means that you will need to increase public revenues or the revenues for the public program that is providing universal coverage. Interestingly, the demand response, if you look at international experiences that we can glean information from, whether that's new co-payments or deductibles that have been put in place in drug plans around the world, the demand response can be expected, particularly for Canadians that are currently uninsured or underinsured, but that's not an overwhelming inducement of spending. We estimated to be on the order of 10 to 15% demand response by the uninsured. And if the savings from consolidated purchasing power, and I will mention improved prescribing practices and better utilization of medicines by patients, if those savings are on the orders of magnitude estimated by a number of actors thus far, which is somewhere in the area of 30 to 40%, of course the demand response of 15% won't be overwhelming. That said, again, part of the political will story here is that we need a government of a province or the government of Canada to say they're willing to move money from what are still voluntary private insurance programs in most provinces into a universal public program. Whether they move it through taxes or premiums is a matter of debate, but you've got to have the political will to say that that's what you're going to do. Once you've done it, you can reduce the total spend quite significantly.
Thank you. We have another question. To what degree does the existence of a large number of pharmaceutical manufacturers having headquarters in Quebec and contributing to the provincial economy have on the cost data? Steve shared some of that on the province's drug costs. Steve, do you have comments to that?
Yeah, so this is part of the political economy of pharmaceutical policy in Canada, and it's actually, there's an interesting book written now probably 40 years ago in the late 1970s or early 80s comparing the pharmaceutical industry's lobbying efforts in Canada, the U.S., and the U.K., and documenting in the 1960s the move of pharmaceutical headquarters from Toronto to Montreal over a period where the industry made a concerted strategy of investing in Quebec, in part because of the political influence that had on not just the province but also on the nation. And so we have to be mindful, absolutely have to be mindful of political economy here. The reality is that the tides are turning in terms of pharmaceutical employment globally and certainly in Quebec. Thousands of jobs lost in that sector over the last decade. And so I think actually the average Quebecer is beginning to realize that they're not getting as good a deal as they wished they were. And I think scholars like Marc-André Gagnon at Carleton University have been doing an excellent job in trying to, as best as possible, develop the cost-benefit sheet, if you will, on that industry strategy for the government. And certainly industry has done its cost-benefit on its strategy as a political economic move in terms of influencing policy.
Thank you. Anything to add? Okay. This next question from Xenia. In terms of personal choice, do Canadian provinces differ in the number of drugs they universal programs in other countries? Basically, are higher costs related to more drugs being funded?
Maybe I'll take this one on just very briefly, if I can. We know in Canada that there's variations in what's covered by province in terms of the formulary listings, but to be honest, the vast majority of drugs used by the vast majority of Canadians are on every province's formulary. The variations in the Canadian context are still in the areas of specialty medicines, cancer care, etc. These are important, particularly if you're a patient with those diseases, and they engender the kind of geographic disparities that Matthew was speaking about. And it's some concern, actually, in a country like ours, that someone might actually consider moving from one province to another because the drug to treat their particular disease is covered one place versus another. But having said that, again, the vast majority of drugs are covered by all provinces, and the vast majority are covered by most countries. The United Kingdom, for instance, doesn't actually have a positive list of drugs that is covered. It only has what's referred to as a negative list, drugs that will explicitly not be covered by the NHS in the United Kingdom. The biggest difference is not what's on the formulary in any given country. It's to what extent are the practitioners weighing the full costs and benefits of their therapeutic choices and making decisions about should the drug being prescribed be an older generic drug, which might be relatively cheap, or a newer, more expensive brand drug? And of course, the answers depend on the patient, but in countries like the United Kingdom, they do have higher rates of prescribing of off-patented medicines and much higher rates of use of generics when those off-patents are prescribed.
Go ahead, Matt.
I was just going to agree. There are differences that you see across countries, and there are definitely differences between New Zealand's formulary, for example, and a lot of the Canadian formularies. You might argue that some of the newer drugs that have come to market recently are not covered in New Zealand, whereas they are here. But to speak to Steve's point, it frequently boils down to whether or not you're covering a therapeutic class or an area of medicine where there are multiple options that could be taken. And if you do the analysis with that lens on, the differences tend to vanish. They don't completely vanish, but they certainly are reduced quite dramatically.
Thank you. The next question is from Logan. The question is, in national Pharmacare system with reduced patient choice, how would we handle the benefit exception process? So how would that benefit exception process be handled in a national Pharmacare system? Perhaps for you, Matthew?
It's been a relatively straightforward process in New Zealand. They do have exceptional circumstances policies. I guess the context here does make it a little bit more difficult. You would have to build that sort of structure into your into any national Pharmacare program. By that I'd mean you'd have to have some budget available to be able to deal with that issue. I think speaking to my point towards the end of my presentation about reduced patient choice, I think having exceptional circumstances, special access programs is actually quite vital to making this sort of system work. So yeah, I can't see you going down this path without having to account for that that need.
Thank you. The next question from Barb and comment, we've talked about this for decades, and while there's been some coming together of pharmaceutical efforts, for example, CDR buying together, we live with the Canadian Constitution. Provinces and territories are responsible for delivery of health care. Without some sort of crisis, financial or otherwise, how do you see any change coming about? National Pharmacare is not top of mind for governments, or for that matter, the public at large. Should we be pursuing the desirable or settle for the doable? Who would like to take that one?
I would argue that we've been settling for the doable for the last 40 years, and it's cost us billions of dollars. So one of the things about mobilizing the governments of the world is to be sure that we remind them that Canadians, deserve better. Part of that means that we need to let Canadians know that their Pharmacare system is truly one of the worst performing systems in the world. And I say this, and I know there are decision makers on the phone here. I have huge respect for the many people who work within the provincial drug plans across the country who have to manage very difficult decisions and actually try to manage a system when they really don't actually hold the reins because they are not actually managers of the entire system. They tend to be managers of particular components with less purchasing power and less moral influence, if you will, over the prescribers in their jurisdictions, owing to the fact that pharmaceuticals are seen in this context as being so separate from the rest of healthcare. So I have huge respect for the people who are in the system today. I think what we need to remind Canadians, though, is that the system is structurally flawed, and it needs to be better. And that requires an effort, a communications effort on behalf of academics like myself, advocates for consumer and patient interests, seniors groups, unions, employers, et cetera. I think when you look at the business case, it's almost, I think, sufficient enough to mobilize Canadians. We just have to get the business case into the right people's hands and have that conversation. And it's true, we have this darn Constitution Act that creates this jurisdictional divide on healthcare in general, but on pharmaceuticals in particular, because the government at the federal level is the level of government that can authorize a drug for sale in the country, and indeed the government that is responsible for monitoring, for instance, drug promotions and advertising. And yet it's the provinces that ultimately bear most of the burden of those drugs being on market, and of the drugs being under patent, which is also under federal jurisdiction. I heard one provincial policymaker who will go unnamed say to me quite candidly recently that the provinces might well embrace a federal government that said they'll take on Pharmacare as a federal program. And it'd be an interesting question for those of you on the line that are constitutional experts as to whether or not there's enough wiggle room in the Constitution Act to allow a federal government to actually become a national, truly national, be it by way of federal, Pharmacare program provider.
And if someone is on the line, please do use the chat function to all participants, and we can start that conversation here. Matthew, before I go to the next question, was there anything you wanted to add?
Again, only to agree. I think the reason for having these conversations is fundamentally to highlight what's being given up here. And if we don't talk about what's being given up, then there will not be any particularly strong reason to look for change. Having said that, change definitely happens when you've got a substantially burning platform, and it would be a shame to have to wait till that platform is truly alight. But as we all know, in public policy, these are often when the tough decisions get taken. So it may be that we still have to wait until governments are finding the red ink truly too difficult to cope with.
Okay, thank you. So there's a model of national Pharmacare already available for biologics provided through the Canadian Blood Services for fractionated biologics for bleeding disorders. It would be interesting to find out the relative price paid per unit for Baxter Advate under a single contract for Canada with Bayer for this product compared to the U.S. and other countries with universal Pharmacare policies. This might help to place the debate in context. Any thoughts about this?
Yeah, I think that's a really great question. It's always struck me as quite unusual that Canada has, in this environment, managed to essentially create a national program for blood products. And you see this across other countries as well. Certainly, I would say very cursory look. This doesn't have a great deal of empirical evidence behind it, but certainly what I've seen in terms of some pricing around these products, you know, again, Canada is not pushing the boundaries of going after decent prices in this area. So there is still would be, I would suggest to you, quite an opportunity in that space, and goes back to the points I was making. You can have the universal program, you can have it structured nationally, but you do need other incentives in there as well if you are to actually draw out things like expenditure reductions and you know, have impact on some of these equity issues. So the other policies definitely have to complement it if you're really going for that, might call it that trifecta of outcome benefits that I highlighted.
Thank you, Matthew. Steve, anything to add?
No, other than also to reiterate, it's a great question, and I think when people say, oh, could tendering work or could purchasing power be exercised in a Canadian context, we need to remind people that whether it's blood products, vaccines, or virtually every single drug used in Canadian hospitals, we have examples of well-functioning, in essence, single-payer systems, at least within the given institutions, that do negotiate on contract. And I want to be clear, too, and I've said this in other contexts, that a system of single-payer purchasing can be in the interest of particularly branded pharmaceutical manufacturers or the generic manufacturers that are willing to sharpen their pencils and bring their prices to competitive levels on an international stage, because some players will win. They will win because they will get a national market. They will win because they will get more patients into their system. And as Matthew alluded to earlier, provinces are increasingly negotiating product listing agreements with manufacturers of new products. As we become more sophisticated and we develop better databases to track and monitor the use of these medicines in the system, Canada can actually develop innovative contracts that provide favorable opportunities for those manufacturers, so that if they bring value for money to the table, or they bring a new product that is providing therapeutic value at given price points in the Canadian marketplace, we should be able to reach agreements. We should be able to reach, as Matthew calls them, a deal that is truly a deal for both the purchaser, the Canadian system, and the provider of the medicine.
The next question is from Catherine. Issue of potentially reduced patient choice seems like a sticking point in the development of political will, especially since media coverage of pharma issues are often about formulary limits and geographic variation. The recent example, Kyla Deco. How might we better communicate these types of trade-offs and build public support for universal but not unlimited pharmacare?
So that's a great question, and this question about how do you get the public, the masses, to understand these very difficult trade-offs is a challenge not just for Canada. It's a challenge globally, where countries around the world increasingly face very difficult decisions about rationing, very high-cost treatment for patients that have very serious conditions. In the Canadian context, we usually call these drugs for rare diseases, but the increasing challenge financially, ethically, clinically, and legally around what should you or should you not cover for serious unmet healthcare needs is something that, with or without Pharmacare, we will struggle with. With Pharmacare, I think you have a better narrative, a better opportunity to have a meaningful public dialogue about trade-offs and about when is it appropriate for Canada to reach out with what some people refer to as a life-saving drug, and when is it appropriate for Canada to say no to the manufacturer until the price is brought down to something that is representing a better value proposition to our system. So it's a great question, not unique to Canada. We probably can learn from countries around the world on this front, and also an issue which is going to exist with or without Pharmacare. As I said, I think it probably will be an easier conversation when we truly have a universal system in place, so that people understand that it is the public interest that decision makers are trying to pursue.
Yeah, and I'll just add that the discussion, if you like, has to become one of understanding opportunity cost. So I think what goes unstated in systems like Canada is really what's being given up as a consequence of the policies we follow. And sometimes what we're giving up is truly not very visible, and we need to highlight and give visibility to some of those things. So, and I think when we talk about this, we have to talk about it in terms of public expenditure programs. We can't simply talk about what we're giving up in healthcare. Now, it's quite a difficult story to talk about, but it's ultimately the one we have to talk about. So you see social welfare programs suffering, you see housing policies suffering because of lack of resources, and you see resources going into a sector that, by international standards, over many, many years has been one of the most profitable around the world. You have to have those discussions, talk about what's being given up. It's I'd hazard to say it becomes within, for example, New Zealand system where the Pharmacare managers are charged with managing a budget. They're charged with keeping expenditure within a capped level each year. That conversation is a whole lot easier to have, because under that system, opportunity cost is magnified, and you by virtue of the tough decisions you're facing and the choices that you're having to take, you have to have that conversation publicly about what's being given up.
Okay, so we have about 5 or 6 minutes left for the webinar. 4 questions here that are in the queue. So I'll read the next one from Heidi. Could you comment on the contribution that not filling prescriptions may have contributed to differences shown in out-of-pocket costs among select provinces? For example, in provinces with high deductible programs, the out-of-pocket costs may be lower owing to simply not accessing prescriptions at all versus having access to a plan such as in Quebec?
That's a great question. Very complicated answer other than to say we don't currently have the data to delve into exactly which prescriptions are being skipped. But I am working on a grant with Mike Law from here at UBC's Center for Health Services and Policy Research, and a number of other investigators from across the country that is working to improve our information on this by way of expanding the kinds of questions related to cost-related non-adherence that we will see in the Canadian Community Health Survey. And so I suspect over the next 2 to 3 years we're going to have much more information about this, what I think is a very important question. So maybe I'm going to sound like a classic researcher in the sense that I will say more research is needed, and I'm glad that people like Mike Law are taking the lead on that.
Great, thanks. From Amir, he said he's learned a lot and commented that they're pushing for both universal drug plans, the equivalent of the New Zealand pharmacy, that they wish to call Pharma Quebec, and the new government shows some interest in grouped purchase negotiation of drug prices. Any comments on that?
I would just comment very briefly. I think that the proposal for Pharma Quebec in Quebec is great. It's good that to stimulate the discussion about what kind of role can you have for an agency responsible for purchasing medicines on behalf of the population. And you know, I think it just might work in the context of a Quebec model, and the political will, particularly among the electorate, I think may be there for something new, because I think people are increasingly seeing the cost of medicines in Quebec rising further and further above both Canada and international norms, and beginning to question, you know, are we getting the right deal here? So I think it's a good model, a potentially good model for Quebec, and I think it's something that needs to be looked at nationally as well. One of the challenges with any provincially run tendering process or acquisition policy is that we have national distributional chains, specifically thinking about the chain pharmacies that go from coast to coast. And there may be some challenges for any one province to do something innovative on purchasing, owing to the tremendous market power that these distribution chains, these retail pharmacies have. And we see an increasing degree of concentration in that sector. So it's great to see a province like Quebec talking about this. I'd like to see Ontario talking about this, maybe even during this current election. If you've got a couple or more provinces, particularly of that size, willing to engage in a process like this, then you can overcome some of the hurdles about these the distribution channel challenges for Canada. But you know, we'll see how it plays out. And I think it's encouraging that a political party in Quebec is being very vocal and stimulating this debate.
So perhaps just some quick answers to these next couple questions, and then I'll invite the participants. So I'll show some email addresses at the end to follow up for more details. But Pauline has said, before thinking of having a unique universal drug program in Canada, why not start to fix the many inefficiencies in the existing system? For example, the way the CPMB fixes new drug prices, which results in very high prices, the inability of private insurance in Quebec to use a reference price, the generic price, etc.
My very quick response would be, of course, we need to deal with the challenges of the status quo and any improvements we can make. And I know, again, like I meet with policymakers at the provincial level frequently. They're working very hard to better run the systems that they have in place.
but I don't want to lose track of the longer-term goal, which is to change the system, because they're still dealing with systems that create structural disadvantages to the public payer and to the private payers, for that matter. And we need to fix what we can now, but let's not lose sight of the fact that we need to change the game. We need to get a system that provides better outcomes, better equity at lower cost, and that is a system that's integrated with Medicare.
Steve. And from Matthew, with public plans legislating lower cost generics by using percent comparisons to brand price, for example, 18% of brand price, what impact do you think that has to the PMPRB process? And do you think it is more likely that they would try to maximize brand prices?
Frankly, I'd see the two as decoupled, I think largely because of the Pan-Canadian Pricing Alliance. I don't think the PMPRB is really, in the public scheme, influencing prices that are being paid by provinces who, in particular, who are participating in the Pan-Canadian Pricing Alliance. So yeah, I don't think they need to be related. I don't think there needs to be an offset there, if you like. I'll make a sort of a more general comment. I do find the pricing strategy, or if you like, the expenditure management strategy around generics very unusual and a little disappointing, I think. And the reason I say that is because I really do feel that manufacturers are put in a very invidious. And the reason for that is that you can't possibly expect all drugs to, although I think they can be produced rather cheaply, you can't possibly expect them to all be produced at the same price. So I see regulated price reductions being actually an impediment to actually decent negotiations with the industry. So I'd much rather see the use of requests for proposal, basic trading techniques that get used in any other sector, and decent supply contracting.
Hear, hear.
So the last question, I think it's a good one to end on too, is there's an interesting group out there. Is there a group out there with a strategic plan in place for change? We put thoughts on paper to solve some of these problems, and really who's leading this change? Would either of you like to add?
Yeah, so I'll speak up because I'll plug a couple of initiatives that I'm involved with, but also I'll start off by saying actually I think it's going to be multiple groups that need to help work towards a solution for Canada. I think the research community and our research network that was funded by IHSPR at CIHR has made a concerted effort to generate quality evidence, but also then engage Canadians in a discussion. And so we launched the Pharmacare 2020 initiative, which was started off with a conference and then followed up with some YouTube videos, a new website that provides information in essence, a large infographic format so that people can get the evidence in a format that's appropriate for public dialogue. We're also launching a closing website, if you will, to the Emerging Team Grant later this year, which will provide more evidence and information about what a true strategic strategy for pharmaceutical policy and Pharmacare in Canada will look like. So stay tuned to that. You could probably follow the Pharmacare 2020 Twitter feed and website to just see how things evolve on that front. But I think it also it rests with employers. I'd like to see the Federation of Small Businesses in Canada, as well as the big employers of this country, having a dialogue about extended health benefits and their capacity to manage pharmaceuticals. I think it's important for unions to be part of that debate. And lastly, but certainly not leastly, the health professions in Canada need to be engaged. Canadian Doctors for Medicare have been quite active and vocal about the need for a Pharmacare system that was public and universal. What I'd like to see is leadership at each and every provincial medical association level to say that it's time to bring medicines into the healthcare system in a meaningful way for Canada. And ultimately, for them as practitioners, it's time for them to take some responsibility to make sure that we're prescribing appropriately, that patients are accessing the medicines they need, and that the medicines are representing value for money to the larger system in which they work.
Just to add one other point there, I feel we need to pay tribute to the provincial and territory drug plans who have, within the Canadian context, created this this alliance between essentially separate jurisdictions to deal with trying to have some degree of collective buying power in the hands of drug plan managers. It's to me, it's that is part of the strategy in Canada, and they're making some good headway there. So kudos to them to actually making that happen to some degree without a national strategy on paper. So I think we need to watch that space quite carefully as well.
Very much, and we have come to the end of our webinar time. Clearly, there's lots to discuss and lots more discussion to be had. I would like to thank both of our speakers, Matthew and Steve, for a really outstanding overview and presentation of the issues and what's happening in Canada. And thank you as well to all the participants who have asked really outstanding questions to keep this conversation going. And we hope that there's some email addresses here for you to follow up, and you can follow Steve, for example, at Twitter, just to keep the conversation going. So thank you, everyone. And before you sign off, if you could, you'll see an evaluation form that will pop up. If you could provide a few comments, we'd really appreciate it. And we hope to see you at our next webinar, which is happening May 28th. And the topic is around performance measurement and reporting and how that can improve Canadian healthcare. So we'll see you there. And thanks again, everyone, for joining.
Thank you.